Good morning. Thank you very much for inviting me. First of all, I would like to thank Dr. Jasuja and the Avatar board for inviting me for this lecture, and thank you very much. I want to congratulate them for this 7th incarnation of Avatar. This is the 7th conference that they have, and mythologically, Lord Rama was the 7th avatar of Lord Vishnu. So with their blessings, I'm hoping that Avatar will also transform into a much bigger meeting in the future. So as you heard this morning, ethics and safety, those are two things that are the cornerstones of any interventions, whether it relates to interventional radiology, cardiology, or nephrology. And my goal today, these are my disclosures. I have research support. And what I'm going to define today is the components of safety of interventional nephrology and what are the tips that you can use to stay safe. And I am also going to briefly mention the success and safety of procedures done by the nephrologists in the past. So what is really safety? Safety is defined by the Agency for Healthcare Research and Quality as freedom from accidental or preventable injuries produced by medical errors. There are a number of medical errors. We are all human beings and we make errors. So to reduce them, if you follow a protocol, it's usually easier. So in interventional nephrology, the important components are 4. One is radiation safety, sedation safety, radiocontrast safety, and procedural safety, obviously. So I'm going to very briefly touch on all of those because these are all very big topics by themselves. So as you know, X-rays are produced when the kinetic energy of electrons is converted into electromagnetic radiation, and you need a certain amount of a good kVp. This is the voltage that you need to have to get a good image, at the same time keeping the current much less so that you do not expose the patient to the harmful effects of radiation. So radiation has a big potential of changing things within the body. So there are certain types of toxicity that are called deterministic injuries. And deterministic injuries are the ones that are related to a threshold dose of the radiation. So if you expose to beyond that threshold dose, you can cause a post-procedure injury that may sometimes be even visible right after the procedure as an erythema of the skin, as you can see in this picture. Depending on the dose, going from 2 grays to 6 grays, you can have mild to moderate to severe erythema. You can get hair loss going from 3 to 7, and it can become a permanent hair loss. And at 10 gray, you can actually get tissue necrosis, as you can see in the picture, in the second picture. Now, ironically, when we talk about Avatar, we have to talk about karma. And the air karma is really different. It's not the mythological karma. And what karma is the kinetic energy released in matter. So electrons release energy, and this is the energy about 6 inches in the air from the patient. And that is what, if you measure that, there is a threshold of that can lead to deterministic injuries. The second type of injury is called the stochastic injury. And this is a totally different type of injury that is related to a linear non-threshold dose that can lead to radiation in neoplasm or heritable genetic defects in the future. Higher the dose you use, there is a more likelihood that you can have these effects. These are measured in the units of sievert. So while the karma air is important for the deterministic injury, for the stochastic injury, you take the entire X-ray field and multiply that by the air karma, and that is what is considered to be responsible for stochastic injuries. How do you get radiation exposure? It depends on 2 things. What is the patient looking like, and what is the procedure? If you have an obese patient where you are going to have to use a higher dose of radiation to get a good picture, that's more likely to cause radiation exposure. And if you have a complex case, a thrombectomy where you have to do a stent and you are having trouble passing the wire, that is what is going to lead to a higher exposure to X-ray. Operator, procedure technique, how well you are trained, can you reduce the amount of exposure, and are you aware of what are the limitations of your equipment, and what is the dose, and if you have the dose written on the X-ray screen, that will keep you aware of reducing that amount of exposure. The sources of radiations are related to the leakage of radiation from the equipment and from the beam of X-ray that is hitting the patient and then scattering around all over the room. So you have to use proper equipment. So how you achieve radiation safety in interventional nephrology is related to a principle commonly known as ALARA. ALARA stands for as low as reasonably achievable, versus NIWID means no idea what I'm doing here. So you have to be very, very careful about, you should know exactly how much radiation you are using, and that relates to how well you are trained in radiation education and training. We always train all our fellows in radiation first before they start doing procedure. And you have to optimize the patient dose from the onset of the procedure, and you have to use a radiation safety program and be really aware of this. How can you reduce the radiation dose? Is by pre-planning the procedural imaging. Save the dose. Don't keep fluoroing. Store the previous image. Don't have to look up again and again and try to work on that. Limit the cine, the magnification, and steep angles. When you use steep angles, there is more radiation scattering, which will go around in the room. And if you have on-screen dose assessment, that also keeps you aware how much dose you have already used. You should use dosimeters. These are for your protection. You can put one on your collar, one on your belt, and that keeps measuring your level of exposure, because eventually, day in and day out, you are going to be exposed to a high amount of radiation otherwise. You should maintain the distance, avoid any body parts within the field of radiation. Now, this is not really the way you should work, not use human shield. So there is only one lad, and everybody else is just trying to hide from that. So this is not the safety. You have to be very conscious of the radiation safety. Now, switching gears, going to sedation and analgesia safety. So very important component of procedures. In US, we are supposed to use sedation to keep the patients comfortable. There is a survey that later on goes on and is reported on the websites as to how well you are doing in keeping the patients comfortable. So, but then there are risk factors for everything that you use. If you are going to use sedation, you should be aware of those risks for complication. The risks are usually related to age of the patient, their American Society of Anesthesia physical status, what drugs you are using, what dose you are using, how deep the sedation is going to be, and what is your skill as a practitioner, and how well you have been trained to use those drugs. Fortunately, we have not had any event where we over-sedated the patient who required intubation or some intervention to wake them up. So that's a very important aspect. So how you select the procedure for patient for the procedure is very, very important to avoid sedation-related complications. So first, you assess their American Society of Anesthesia classification, how healthy they are versus what bad comorbidities they might have that may put these people at risk for sedation-related complications. You should take a history to identify risk factors. You should know if they had previously anesthesia and sedation, and did they have any complications. If a patient is pregnant, you may not want to give too much sedation either. And there are certain important baseline measurements that you want. You want to weigh them because you will be dosing according to the weight. You should know the vital signs, what is their oxygenation, what is their cardiac status, and neurological status. And you have to assess the airway in case they need intubation later on. So you should be prepared. So everything is about being prepared for these things. So Mallampati classification, which is commonly used, thyromental distance to look at the neck length. If there is a short neck, it's more difficult to intubate. And interincisor distance to make sure you can open the mouth to put the tube in, and whether or not these people can extend their neck. Now, in case something happens, you should be ready for that. So you should have antidotes available. So naloxone is an opioid antagonist that you have to use. Flumazenil is a benzodiazepine antagonist. You should know the dosages. You should know the limitations. You should know that the half-life of flumazenil is not long enough, and the patient can actually go back in sedation a little bit afterwards when the effect of flumazenil wears off, and you may have to redose the patient. So those things are important to understand. And you should always be ready for, no matter how prepared you are, there are going to be some events that you have to be ready for that. Whether those are cardiovascular, respiratory, or neurological, you have to be prepared for those. So routinely, when we give sedation in US, we have to monitor the patients with electrocardiogram, pulse oximetry. We have to have essential equipment available, the oxygen. You may need positive pressure ventilation. You should have a backup plan. So it's important. you should not be the only one in that room who knows how to revive a patient if there is an emergency. Everybody should be basically life support trained, and we are required to be trained in advanced cardiac life support for that reason. Now moving on, the third component is the contrast. Contrast is the backbone of imaging in interventional nephrology procedures. Otherwise, you cannot get good idea about the vessel's health. So iodinated radiocontrast agents are the most commonly ones that are used. We do not use gadolinium, obviously, because of the potential for risk of nephrogenic systemic fibrosis. And when we use radiocontrast, we use non-ionic contrast, because ionic contrasts are more hypertonic. They are more likely to cause injury than the non-ionic contrast. Now remember, Dr. Sachdeva also mentioned that you can use a small amount of contrast without causing nephrotoxicity. So that is perfectly safe. So don't be worried about that. I've not seen any patient going in renal failure from my procedures or losing their residual renal function. CO2, carbon dioxide, is a good imaging agent that may be an alternative for the patients where you cannot use iodine because of whatever, it may be the allergy or whatever. But that requires special equipment, special training, and there is a risk of air embolism. So there are two different types of iodinated contrast toxicity. One is the dose-dependent toxicity, and one is dose-independent. Dose-dependent toxicity is nephrotoxicity, and I don't need to teach this audience about the nephrotoxicity and what you should be looking for. Hyperthyroidism and thyrotoxic storm is another possibility that can happen with use of excessive amount of radiocontrast. Now, dose-independent contrast toxicity, not as common, but is more difficult to manage at times. There are three different categories of those. So the easiest ones are the vasomotor ones, where you get just flushing and warmth, and you can potentially just simply reassure the patient, maybe use some Benadryl, and that will be all what you need to do. Vasovagal reactions are the other ones, where you can have hypotension and dysrhythmias and convulsions, and you should have the drugs available to treat those. And the third one is the most severe one, which is the anaphylactic reaction. Now you are into something serious with the laryngospasm, bronchospasm, respiratory failure, and urticaria and hypotension, and you may need corticosteroids as well as epinephrine and Benadryl and IV fluids sometimes to revive these patients. So you should be aware of all those risks. This is extremely, extremely important. Now, my talk on safety cannot be complete without talking about procedural safety. So you are doing procedures, you have to be aware that more procedures you do, you are likely to run into some type of problems. And if you have not run into any problem, you have not done enough procedures, right? So you always have to be aware that there are going to be some complications. So ASDIN has classified some of these procedural complications from 1 to 10, but the top 5 are related exactly to the procedures. The axis, which can go from is type 1 to type 5. Type 1 is access site hematoma, going on to vascular rupture and arterial complications and stent and catheter-related complications. So you should be aware of those. Not only those, you should know their grades. And the grades are based on how severe the injury is, how much more interventions you will need to do to take care of those complications, and are there going to be some serious consequences or not. If these are mild, then you go to grade 1, and if they are really serious and you end up losing an arm or the function, which hopefully you don't get, will be the grade 4. So it is very, very important to have a quality assurance process in your lab so that you can track these things and stay safe. Now, very briefly, just wanted to let you know that very early on, there was a doubt that the nephrologists will not be able to do these procedures safely. So this was a publication that was the landmark publication back in 2004. The figures in the back are the minor complications. Figures in the squares in the front are the major complications. As you can see, there's a very small incidence of minor and major complications, which were better or similar to other operators like radiologists and cardiologists and surgeons. This is really established the field of interventional nephrology, that these procedures can be done safely by the nephrologist. To summarize my talk, it is important to follow radiation, sedation, and medication safety in the perioperative period in interventional nephrology. You should be able to track your procedural complications, measure their grades, and use those for quality assurance purposes for the future. In the past, the procedures performed by nephrologists have been safe and effective, and it is extremely important to continue to follow those protocols and appropriate safety measures, which can only come by proper training and education to keep these procedures safe. With that, you have to remember that there is no shortcut. Safety is always first. Primum non nocere is still the principle of medicine, and we should follow that. Thank you very much for your attention.
Thank you, Prof.